Good morning, everybody. Before I start, these are my disclosures, and you can see they're not relevant for this particular session. So when I was given this title, I needed to think about areas of controversy, and of course I raise a lot of controversy myself. So I wrote those down on the right-hand side and then decided I could only talk about two of them. But I wanted to give you an update on where we are with PI-RADS-2 and its performance. But I did want to introduce the whole new concept of the PI-RADS pathway. So the PI-RADS pathway was introduced about 10 days ago. And all of you would have had an email with this paper. And we would like you to read it by yourselves, but also circulate it to your colleagues as well as your urologists. And everything I'm going to say today is in this paper, so no need to take pictures. It is all there. The first thing we need to ask ourselves is, using the PI-RADS system as it is currently formulated, what do we see? What do we miss? And, being very honest. So it is undoubtedly true that we see large cancers of higher grade if they are index lesions, right? This has come through again and again in the last 24 hours. We will see Gleason 3 cancers if they are solid lesions, but not the sparse type of disease. On the other hand, if you are using endorectal coils, etc., you could see smaller lesions, but for the majority of us, we will see the larger, higher grade, non-cibriform, solid patterns of disease. But we have to be honest, we do miss lesions. Some lesions we want to miss. So for example, the sparse type 3+3 cancers, we want to miss. But we also have to acknowledge that the cibriform pattern, the mucinous carcinomas, we are missing. So anybody who tells me you've got 100% sensitivity, 100% specificity, it's not true. The data does not support that. Now, one of the most interesting questions that you need to ask yourself is, if I see a lesion and I could put a needle right in the middle of the lesion, how often is that going to be a cancer? So this is probably the most precise study that there's ever been published. 1,000 patients with targeting inside a scanner with 1 to 2 millimeter accuracy. You cannot do better than this. And essentially it shows that the higher the PI-RADS score, the more likely it is that there's going to be cancer there, right? No surprise to anybody at all. But be very careful of this data. Because this is a mixed population, you cannot say that 34% of patients with a PI-RADS 4 is going to be a cancer if you precisely targeted that. Why? Because this is a mixed population. So you have to look somewhere else. And where you should look at is this paper. This is probably the best paper. About 340 patients, 740 lesions, ultrasound fusion biopsies done in the United States. What you notice is, and they are looking here at cancers that could kill you, right? So these are cancers that could kill you, 3+4 cancers and above. And you can see that if you have a PI-RADS 4 lesion, about 22% of those lesions will be a 3+4 or greater. That is very strange. That is very strange, because in our brain we have a figure of about 40. But on a lesion per lesion basis, it's only 22%. Okay. Now, what about will kill cancers? These are cancers, if you don't find them, they will kill the patient. So these are, do not miss these cancers. What you find is the same data looking at 4+3 and above. A PI-RADS 4 lesion that you see on an MRI scan, 11% that is going to be a will kill cancer. Actually, it's much lower than you think. But on a patient basis, the data is completely different. So lesion analysis and patient analysis is different. So before we talk about the patient level analysis, why is it that you can see a PI-RADS-4 lesion and it turns out not to be cancer? And how often does it happen? It turns out that half the time the tissue is normal. Even with a precision of 1 to 2 millimeters, the lesion, the half of them will be normal tissue. The rest, the major cause, non-cancer cause of a PI-RADS-4 or PI-RADS-5 is inflammation, right? It's prostatitis or granulomatous prostatitis. And so typically it's something like this, PI-RADS-5 lesion, this is granulomatous prostatitis. This will trap you again and again and again. So you need to be very aware. Now let's go back to patient level analysis. To my mind, this is the best paper published on the performance of PI-RADS or PI-RADS version 2 at a patient level. This is 807 patients. Very interesting. On a patient level, you can see that 20% of patients with PI-RADS 1 and 2 will have a clinically significant cancer defined as 3+4 or above. Interesting, right? So hang on a minute. What are we saying here? We're saying that 29% of patients will have a negative scan, but if you were to sample that with high-density biopsies, 20% of those patients, 1 in 5, will have a clinically significant cancer defined as 3+4 or above. Now that is an interesting and salutary lesson. This data is not an aberration, because if you look at the PROMISE data, you see the identical statistic, right? So this is looking at 3+4, not the primary definition that was used by the PROMISE investigators. This is looking at 3+4 or greater. And again, you can see that significant cancer prevalence was about 50%, 27% of patients had a negative MRI, and the Gleason 3+4 or above is 24%. Identical. So those two papers, prospective studies, multi-center, have identical data. So let me just show you that in a table form. So PROMISE, Hansen, Precision, and the latest Baduk paper, you can see the prevalence of negative MRIs is identical. 27%, 29%, 28%, 30%. So 1 in every 3 will be negative. And then the question is, what is the prevalence of clinically significant cancers in those? And it is less, and that we'll come to that table. So the first question you should ask, and this is the first controversy, what the hell do we do about negative MRIs, right? You have negative MRIs. So you need to know what is the prevalence of could kill cancers in negative MRIs. And here is the data from the largest studies, which are level 1 studies. And you can see it is between 17 and 24%. So 17 to 24% of patients with a negative MRI with high sampling density will have some 3+4 cancer detected. Now, what should be the natural response to this statistic? Do we just fire some needles into the prostate just in case, right? Just in case we can hit it? The answer is no. Why? Because the yield of a random biopsy in a negative MRI is 5 to 7%. You can see, I have looked at every single study ever published on this, right? I've even written to the investigators and said, this was not in your paper. What is the statistic? And actually, it's 5 to 7%. So if you have a negative MRI There is no point in just firing a random set of biopsies into the prostate just in case, because the chances of you finding something is 1 in 20, right? That is useless. So how do we improve the negative predictive value of a negative MRI? In other words, how can I make the MRI even better? You can use PSA density. And PSA density can allow you to be even safer in omitting a biopsy in patients who have a negative MRI. The next question is this a safe thing to do? If you don't biopsy, is it safe? What happens to these patients over time? Now, this is data from Valerie Pennebianco, who looked at over 1,000 patients and followed these patients for 5 years. Negative MRI scans for 5 years. And what you notice is you are free of clinically significant cancers for up to 5 years in 95% of cases. So if it is a safe thing to do, if you follow these patients, 95% after 5 years will still not have a cancer, which is interesting. And when you find the cancer, and you see most of the cancers in the next 2 years. And when you find these cancers, all of them are curable. So you can wait, you can survey, PSA surveillance. When you find them, they will still be curable. So then the question arises, who should follow? Should it be the GP? Or should it be the urologist? Who follows? And this brings me to the prostate cancer, the PI-RADS pathway. And this is what has just been published. So what we as a steering committee think is that if you have a PI-RADS 1 or 2, i.e. a negative MRI, and if your PSA density is less than 0.1 to 0.15, depending on the local MDT, it is safe to do PSA surveillance. And if you have a low PSA density, a GP can follow, but a urologist should follow if the PSA density is high, or there are other risk factors such as a strong family history or a genomic score that's abnormal, or a risk calculator says that there's a higher risk than the background. So this is the guidance that we are now putting forward. The other controversy is, what do we do about positive cases? Positive cases. Do we do targeted biopsy alone, or should we do systematic plus targeting? And you can see I put down 2 articles, one of which says do no harm, the other one says leave no cancer behind, right? So this is a controversy amongst urologists, and you can see one is in the New England Journal of Medicine and one is in the Journal of Urology. So this is a controversy. The first question you have to realize is that if you do MR targeted biopsies alone, and you compare that with MR targeted biopsies with a TRUS, a systematic biopsy, there are about 5 to 15% of patients in whom only the systematic biopsy diagnose a clinically significant lesion. We have to acknowledge it, the data is immensely strong. The question is, why is MR targeted biopsies missing stuff? Why does it happen? Well, it could be the MRI, right? It could be the MRI, the fact that you have a lousy scan, but it's not only that. It's you, it's readers, how you interpret these images, whether you recommend biopsy or not, and how. It could be the lesion location. So we know that if you have a large gland and a transition zone tumor, you're more likely to miss than a tumor in the transition zone than in the peripheral zone. But you know what? It's not just the radiologists. It's the person who's doing the biopsy. So your surgeon who's doing the fusion biopsies, his training is also important. So they can't blame us. They miss because they don't know how to read MRI. So training for them is also important. The other thing you have to realize is there is intratumoral heterogeneity. So you can have an area that's Gleason 3+3, and next to it you have 3+4, and you may not biopsy the 3+4, you just go for the 3+3, and that gets you the wrong answer. So there are multiple causes of these errors. So the real question is, what's the trade-off, right? What is the trade-off? What is the trade-off between targeted biopsies alone and targeted plus TRUS? Which one should you do? That trade-off is shown on this table. 3 papers have looked at this very carefully. And essentially what it says is that you need to do 14 to 18 combined biopsy to find one additional clinically significant cancers. So you have to do 15 biopsies more or less to find one clinically significant cancer, but what you do is you overdiagnose clinically insignificant cancers, about 1 to 3.7 insignificant cancers. So this is a trade-off, right? This is not a trade-off that you can make. This has to be done at an MDT. You have to decide as a group, working with your clinicians, what is the overall trade-off and how are you going to approach this? The big question from a sort of government level is, well, are the overall pickup rates of clinically significant disease impaired by doing only targeted biopsies? Are the overall clinically significant detection rates impaired by just going for the targeted biopsy? And you know what? This has been answered by the Precision trial. This is a randomized study, New England Journal of Medicine. You can stand up and say, actually, it's not impaired. The fact that you go for targeted biopsies alone means that 30% of patients will be spared a biopsy, right? That's one advantage, and you'll notice in the PROMISE study it was 27%, right? So it's very close. You will have fewer cores, you will have less complications, and you know what? You still get the advantage of more clinically significant cancers and the advantage of fewer clinically insignificant cancers. So you can get all the benefits by going for a targeted approach alone. So there is a good, strong level 1 study that you can stand behind this data. But what do the guidelines say? The guidelines are like this. The NCCN is like this. No recommendation. EAU, no recommendation. AUA, no recommendation. Nice, no recommendation, right? The only guideline that comes out and says something is the UK consensus guideline, and now the PI-RADS committee has said, actually boys, we have a view, and this is our view, right? So what is the view of the PI-RADS committee? Well, the PI-RADS committee has to balance the do no harm aspect and miss no cancer aspect. It has to balance that. So if you are a biopsy naive man, you must try to find all the cancers that will kill the patient if you miss it. That's important. On the other hand, it's also important not to overdiagnose insignificant cancers for all the reasons that we heard about this morning. So that balance has to be right for biopsy naive men. That's where this table, again, in that document, comes through. And essentially, what it says is it gives you a recommendation on what to do with a negative MRI, with an intermediate MRI, and a positive MRI. And I'm not going to go through the various options, but just to tell you that it's in that document, and please take a look at it. So this then brings in this whole concept of the PI-RADS-MRDB directed biopsy pathway. Okay, and again, there's been a Twitter stream talking about this pathway, which is shown here in brief with the benefits on the left-hand side. So there is a benefit to using a MRI and an MRI targeted biopsy in biopsy-naive men. Remember, all the guidelines committees are silent about this area. So we as radiologists should say, excuse me, we as radiologists think that this should be done. And these are the advantages that we can get. Now, the elephant is that many of us are not giving contrast. Everybody talks about multiparametric MRI, but I guarantee you, and I know for a fact, that 36% of you are not giving contrast. Right? How do I know that? Well, I have a spy. Okay, 36% of you. Okay, so the question is, what about biparametric MRI, and what does the PI-RADS committee think about the biparametric MRI? And this paper has just been published by Vibeke and her colleagues, and it is incredibly provocative. Essentially, it says that a negative MRI can be defined on the basis of a T2 and a diffusion, and if I just want to avoid a biopsy, that's all I need. Everybody else is going to get a biopsy. Makes sense? The rationale is sound. So, all you need to say is, I am not PI-RADS 1 and 2, biopsy me. That's the only decision you need to make. Well, that's an interesting and provocative statement. Then you say, okay, what would be the test performance of that approach? And this Baduk study has just been published, and the interesting thing is the overall clinically significant pickup rate is not impaired by getting rid of DCE. Interesting. 30% of patients can avoid a biopsy. There are 8% fewer in clinically insignificant cancers. Interesting. Interesting and provocative. Right? So the overall detection rate of clinically insignificant cancers is not impaired in a prospective study. Is this enough? Is this evidence enough to go forward? And the answer is no. It is one study at one center done prospectively. We need more studies. And in fact, within the next year, we can expect data releases from these two studies. These are multi-center prospective clinical trials, one in Finland and one in the Netherlands. If these turn out to be positive, then it will completely change the game. And so the PI-RADS committee is keeping a very close eye on this. So these are my conclusions. We know that that trust biopsy performs poorly. MRI can identify about 30% of patients who can safely avoid a biopsy. That number seems to be quite good in non-screened populations. We can reduce the number of clinically insignificant cancers. We can increase the number of clinically significant cancers, but we have to accept we do not find all clinically significant cancers depending on the definition. We have to realize that our performance depends on the definition of clinically significant disease. We have to, as a community, assure the quality of the diagnostic process. That is to say, the MRI, the reading, and the biopsy. It has to be all three. Not just you, but also the biopsy. That means everybody participating in this has to work within a robust, multidisciplinary team. Thank you very much.